Welcome back. This is video number 11, Myocardial Bridge Assessment, Part 2. We will discuss these items. In this video, is this a long bridge or two bridges in the LED? What about the segment opposite to the diagonal origin? We can see a mid and distal myocardial bridge segment with a diagonal branch in between. The first segment is a superficial myocardial bridge confirmed by CT. Notice the closure of the septals with systolic compression of the segment. Systolic closure of the ostium of the septals is also seen in the lateral view. While in the distal segment, there is some atherosclerotic plaque with an apparent systolic compression. Notice absent septals with a systolic contraction. Yet the CT considered this segment free of bridge. As we can see in the CT image, there is direct contact of the artery on the myocardium in the distal segment, which increases in systole. This is called encasement. Myocardial bridge is initially classified into two types. The superficial variant, about 75% of cases. The LED is in the normal position in the intraventricular groove, yet crossed by an overlying muscle band, while a deep variant in which the LED deviates and dives into the interventricular septum. In CT images, this deep variant is sometimes referred to as encasement. Normally, the LED white dot is away from the myocardium in the IV groove. With partial encasement, the LED lies with direct contact with the myocardium in the floor of the gorge of the IV groove. While in cases of full encasement, the LED lies within the myocardium of the groove, either superficially or deep. Normally in systole, there is thickening of the myocardial wall, so the artery is nearer to the myocardium, and downward displacement of the longitudinal axis of the groove and the artery. When there is encasement, the artery is near to the wall. So in systole, the artery lies on the wall or a passing RV band or dives in it. In this case, partial encasement explains the situation. With systole, the artery is compressed by the thickened infralateral myocardium, which is in direct contact with the floor of the artery, and the septals are closed. Some distal tortuosity with fixed superior, proximal, and distal points and plaque adds to the impression of a superficial myocardial bridge segment. Notice the closure of the ostium of the septals with the systolic compression of the segment. Partial encasement as part of the proximal myocardial bridge segment explains the stenosis opposite to the diagonal bridge. And this is confirmed in the CT. And these are the CT images of short and long axis of partial LED segment encasement in the gorge of the IV groove with no overlying muscle band. When there is no free area between the artery and the myocardium, white arrow, a short axis view should be taken to differentiate between a mild superficial bridge or encasement and the degree of it. In these figures, figure A to C, there is a case of complete deep encasement, while D to F, a case of complete superficial encasement. In this male patient with severe mid-LED bridging, surgical unroofing was done. The pre-operative CT showed the proximal and mid-course of the bridge. Post-operative CT showed a distal LED myocardial bridge. This bridge is in the inferior surface of the LED. 2 years later, there was recurrence of angina with no recurrence of bridge in the coronary angiography. The CT showed the proximity of the mid and distal LED to the myocardium. Coronary angiography guided with IFR, IVUS, and dobutamine challenge. There was decrease in the IFR with dynamic compression on the ventricular inferior side of the unroofed LED. and the heart team decision was PCI to the mid and distal LED. So encasement alone may cause pain, even later with left ventricular hypertrophy acquired myocardial bridge. Stenting in complete encasement is an option, especially if IFR and IVUS guided. Awareness of the surgeon of the presence and extent of encasement, even if partial, is important for decision of the site of anastomosis distal to it, and lima grafting instead of deroofing is preferred. Deroofing has no rule. A detailed CT information is crucial. Systolic contraction may also appear significantly in the PA and LEO cranial views if there is a dominant lateral compression than the inferior wall. This occurs if the artery is diving towards the RV or LV. Encasement explains the following. Dynamic compression may occur in segments without overlying muscle. It may not occur in patients with overlying muscle not entrapped. Dynamic compression length was greater than that of the tunneled segment in many cases, and occurred almost exclusively in the LED. In this mid-LED bridge, what is the length of the bridging segment? Angiographically, the length of the bridge is more than 25 millimeter, from 0.4 to 0.2. In this case, the angiographic compression segment yellow bracket includes the overlying myocardial bridge segment, which is 15 millimeter in the CT, mostly also encased, and the encased segment much longer than the bridged segment. Unfortunately, no short axis view was taken to detect the encasement or a superficial myocardial bridge. Actually, with a thorough look to the distal segment of the artery, the longitudinal axis and the upper border moves to the center in systole, yet the lower border doesn't, due to encasement. Typically speaking, systolic contraction is in the inferior or lateral border. Normally in systole, there is shortening in the longitudinal axis of the LED, and the axis of the artery moves towards the septum, and the adjacent RV-LV wall thickens in systole or with left ventricular hypertrophy and becomes nearer to the artery. When the LED is free in the groove, there is a safe dead space from the ventricular wall, yellow arrows. This allows for a normal, safe, systolic approximation to the wall without a decrease in the lumen. Also, the ostium of the septals travels safely in this space. This also compensates for any decrease in the lumen area with an overlying bridge, even if deep. So depth of overlying muscle band may not correlate with significant systolic compression. If it lies on the wall, usually the RV, especially with hypertrophy or bridging muscle band, there is no safe dead space. This causes a decrease in the lumen in the systole, which adds to any decrease if any overlying bridge is present, and ostial septal closure. In these figures, figure number 1 and 2 are myocardial bridge, superficial and deep. Only in figure 3 there is an entrapped myocardial bridge in which the artery is entrapped between upper and infralateral borders. The more securely a vessel is entrapped in a confined space groove, the more vulnerable it will be to the squeezing force between the walls. It is also suggested that a long segment bridge may help in this entrapment. So the following conditions is needed for a myocardial bridge segment to produce a significant dynamic compression, regardless of the depth of the overlying muscle in CT. The vessel is positioned in such a location that a squeezing force can be inserted between two contracting walls, overlying myocardial bridge and RV or LV wall, or a vessel is totally entrapped with full muscle encasement. In addition to liability for spasm in the bridged segment or the artery. Both encasement and myocardial bridge may occur in the same segment. The LED white dot lies in the apex of the IV groove on the septal muscle and surrounded by muscle bridge. The tunnel segment due to encasement and bridge was about 15 mm, while the myocardial bridge length is 26 mm, and the whole systolic compression was about 25 mm. Notice the absent third septal artery in systole. Absence of LED entrapment, although a 6 mm depth, may explain why this old patient is well controlled on medical treatment. In this case, mostly there is no encasement if there is upper border systolic contraction with a nearly absent lower border contraction, especially if the septal artery is preserved in systole and in the presence of tachycardia, as in this case. Regarding imaging, when any CT report is needed, these questions should be answered. The myocardial bridge segment length and depth, degree and length of compression, encasement length and degree, presence or absence of atherosclerotic plaques and lesions, left ventricular wall thickness. This is an image of a deep myocardial bridge of LED, yellow arrow, close to the RV. And the depth of this myocardial bridge in the mid-LED is 4 mm. In this case of HOCM, septal wall thickness was measured, the depth and length of the myocardial bridge, the systolic compression decreased from 2.2 mm in diastole to 0.9 mm in systole. LED bridge in this case is superficial since no overlying myocardium is seen, while in the CX bridge it is deep with significant myocardial mass overlying. In IVUS, there is half-moon phenomena or halo sign, which is highly specific, only detected in myocardial bridge, in which there is an equilucent area surrounding part of the circumference of the artery. Most probably it is due to muscle band. Also, the IVUS may detect variable degree of compression that persists into diastole. According to the variant, the muscle band may appear lateral or lower to the artery from any direction. Notice the thickening of the band in systole. In summary, angiographic assessment of myocardial bridge has many drawbacks in many cases, yet assessment, if correlated with clinical interpretation, it will help to decide what is next, CT or medical treatment. CT images answer all the questions only if all the required data is asked for. Encasement, which is a variant of myocardial bridge, should not be under-evaluated in CT or as a cause of ischemia or acquired myocardial bridge. It is essential to know the extent and the degree of encasement to decide the type of surgical repair and the site of anastomosis. And this is the end of the video. Thank you for your attention and waiting for your feedback.